Welcome to our presentation, Differentiating Bipolar Disorder and Disruptive Mood Dysregulation Disorder. Before we begin, I'd like to introduce myself to those of you who are new to Children's Mental Health Resource Center. My name is Elizabeth Errico, and I'm CMHRC's Executive Director. Our mission is to provide guidance and resources for the early identification and management of mood disorders. That includes disorders such as bipolar disorder and its newly identified phenotype, thermoregulatory sleep dysregulation disorder, which is more commonly known as fear of harm. Please feel free to put your comments and questions into the chat or into the Q&A. Do not raise your hand. We will not be able to activate your microphone or camera during the presentation. My colleague, Angela Jameson, is behind the scenes answering questions as we go and holding ones that are asked multiple times for our live Q&A at the end. So for now, sit back, relax, and we hope you'll enjoy this presentation. Our learning objectives are that by the end, participants will have examined the history of the development of disruptive mood dysregulation disorder, can describe the diagnostic criteria for bipolar disorder and disruptive mood dysregulation disorder according to the DSM-5 revised, identify the clinical features that differentiate bipolar disorder from DMDD, and to give examples of current evidence-based treatment approaches for both bipolar disorder and DMDD. Now, hopefully, my colleague will be able to put this poll onto your screens that we are going to ask you to fill out just to get a sense at the outset of where people are in terms of their understanding in differentiating these two diagnoses. So take a moment to fill that out. And by the end of our time together, I hope that you will have a better framework for both the identification and differentiation process. So back to our first learning objective, examine the history and development of the disruptive mood dysregulation disorder diagnosis. Now, you may have been taught in your graduate program or by mentors and supervisors that disruptive mood dysregulation disorder is just a childhood version of bipolar disorder. So if you were taught that, don't feel alone. This is one of the most common misconceptions in pediatric psychiatry. But the truth is that the research literature is really quite clear on this point. DMDD is not the childhood version of bipolar disorder, despite the fact that there's some overlap between the symptom sets. These are two different diagnoses with some key differences that make it easy to differentiate once you know what to look for. So to understand this confusion, it's important to take a look at the history. In the 1990s and early 2000s, there was a large rise in the rate of diagnosing pediatric bipolar disorder in the United States, that is. And some studies showed that those prevalence rates increased by as much as 40 times. What was noted was that many of these children who were being diagnosed with bipolar disorder presented with chronic, non-episodic irritability, not the distinct, abrupt, and erratic mood episodes that are characterized in bipolar disorder. So before DMDD even came into existence as a diagnosis, researchers were questioning whether or not bipolar disorder in children simply looked different than it did in adults and was characterized perhaps not by classic mania, but by irritability and explosive outbursts. At the same time, there was a big rise in the use of antipsychotic medications to treat mood disruptions in children. And concerns began to grow that children might be misdiagnosed and were being placed on these medications that have a really significant side effect profile. Out of that pushback came the idea that children couldn't be diagnosed with bipolar disorder. And that belief began to sort of take root. And from that root grew the idea that a different diagnosis, other than bipolar disorder, needed to be identified to take its place. But in actuality, what these children needed were clinicians who knew how to tell the difference between complex symptom presentations and to support accurate diagnosis. Because in our system, the diagnosis shapes and dictates treatment, prognosis, how the family and community partners are able to understand the child and their needs, and misdiagnosis in either direction can have devastating consequences. So in response, a researcher named Ellen Liebenloft did additional research through the National Institute of Mental Health. And it drove the DSM-5 working group to create a new diagnostic category. And this is how disruptive mood dysregulation was born as a diagnosis. It was out of this studying of severe mood dysregulation in children. This research into severe mood dysregulation reported that children had distinctly different neurobiological profiles, different family histories, and a longitudinal outcome that pointed towards depression and anxiety in adulthood rather than bipolar disorder, which we will come back to in a minute. So, again, the DSM-5 working group at this point created a new diagnostic category, DMDD, and located it within the DSM-5 in the depressive disorders chapter, not in the bipolar and other related conditions chapter. This new diagnosis, disruptive mood dysregulation disorder, gave clinicians for these chronically irritable children that had been identified a home. It also steered clinicians away from the bipolar disorder diagnosis and inadvertently created significant confusion, in part because there wasn't a new treatment protocol or modality to accompany this new diagnosis. Now, I want to share with you some insight on the development of the DMDD diagnosis from Dr. Robert Post, who some of you may have heard of. Dr. Robert Post was the chief of the biological psychiatry branch at the National Institute of Mental Health for 20 of his 36 years at NIMH. His research focused on a better understanding of treatment for patients with refractory unipolar and bipolar depression. He's a board member of the Brain and Behavior Research Foundation and on the scientific advisory board of the International Bipolar Foundation. He's the editor of the Bipolar News Network and author of the book, Treatment of Bipolar Illness, a Casebook for Clinicians and Patients.
They decided that there was too much bipolar illness in the U.S., so they did things such they could call people something else. But it turns out that the DMDD stuff is not very relevant because they've done studies, Axelson and Birmingham at Pittsburgh have looked at it, and they find that diagnosis goes with almost everything, with oppositional defiant disorder, with ADHD, with depression, with bipolar, with all these things. So it doesn't have any specificity. The other thing is that it has no treatment related to it. If you come up with a new diagnosis, it's usually because there's a new treatment approach, and they don't have it. And I kept on asking the folks who push this diagnosis, so how do you treat these kids? They did a study of lithium, and that didn't work. They made inferences from other data in the literature about what might work, and they said antidepressants might, but if you looked at their data, the antidepressants didn't work very well at all. So there's no good treatment associated with it. So in my view, it's kind of a useless diagnosis. It doesn't help a clinician get anywhere new.
Okay, so these are strong words from a world-renowned expert in pediatric psychiatry. But we as clinicians, we still have to contend with the DMDD diagnosis. Children come into our practices, into our schools with this diagnosis already in place. It's in the DSM. We are expected to use it. So the question becomes, how do we use it? Not as a sledgehammer to frighten people away from the bipolar diagnosis, but as a scalpel that can help us differentiate bipolar disorder from other conditions. Because in the end, our goal as clinicians needs to first and foremost be an accurate diagnosis, not the popular, familiar, or expected diagnosis. So with this in mind, we are going to continue to explore how to differentiate these two disorders. And so first, we are going to look at prevalence rates, which are an important metric, but it is important to note that they are based on diagnostic recognition, meaning that prevalence rates are based on the diagnoses that are actually given, not ones that are suspected or might in fact be the correct diagnosis hiding behind an incorrect one. They are based on what gets written in a medical chart, and based on that data, bipolar disorder has a lifetime prevalence rate of between 2.8 and 4.4% across the general population, with rates increasing throughout adolescence. And it's estimated that between 2.6 and 3.3 of the youth population has bipolar disorder. It's also important to note here that rates are higher amongst the population of children who are already seeking psychiatric care. And that makes sense that those numbers would be higher than the general population. But concerningly, bipolar disorder has the highest rate of severe impairment of any mood disorder. DMDD is estimated to affect somewhere between 2 and 5% of children, with community samples showing around 3.3%. However, rates are also considerably higher in clinical settings, which again makes sense because that would be where people are already seeking care. But there is a huge skew between the 7% of children in psychiatric care who have bipolar disorder versus nearly 22% in the clinical sample who have been diagnosed with DMDD. This is especially noteworthy when we look at the fact that across the population, the difference in prevalence between bipolar disorder at between 2.6 and 4.4 and DMDD at 3.3% is not that different. It makes us really think about what Dr. Post had to say about it. Are we in fact pushing people towards the DMDD diagnosis? And is this statistic and the differential between the statistics evidence of that push? Also of note, DMDD is more commonly diagnosed in boys rather than girls, and it is most commonly diagnosed in children who are still elementary school aged. Now, before we move into the established criteria themselves, I want to pause and acknowledge something that is foundational to everything that follows. The research base that we draw from has significant demographic limitations. The landmark studies on DMDD were conducted on primarily white, English-speaking middle-class families in the United States. Available data on DMDD in low and middle income countries and in non-Western societies is limited. And this influences what is considered diagnostically relevant because we are looking at cultural interpretations of symptom presentation. Specifically with DMDD and bipolar disorder, we're looking at cultural norms around emotional expression and discipline practices. What's considered an extreme temper outburst in one cultural context may be viewed very differently in another. This doesn't mean that these diagnoses can't be given, but it does mean that we need to examine our clinical judgments and reflect on how our own unconscious biases and preconceptions may influence how we interpret the symptoms that we're assessing. The DSM-5 revised edition includes the cultural formation interview. It is a structured tool for integrating cultural context into diagnosis. And if you aren't familiar with it, I encourage you to take a look. And if you'd like more reading on the issue of racial bias in psychology, I would recommend a book by my old professor, Dr. Robert Carter, professor of counseling psychology at Columbia University, and his book on the influence of race and racial identity in psychotherapy. It is particularly useful in informing a clinician's understanding of cross-cultural perceptions. Now we're going to move on to second learning objective. Describe the diagnostic criteria for bipolar disorder and disruptive mood dysregulation disorder according to the DSM-5. Okay, so looking at the diagnostic criteria for bipolar 1, we have to understand the cornerstone of this diagnosis is manic episodes. A manic episode in and of itself is sufficient for the diagnosis of bipolar 1 because when a manic episode presents, the presumption baked into the diagnostic process is that a depressive episode will occur at some point across the lifespan. So manic episodes are that cornerstone of the diagnosis, sufficient in and of themselves to qualify for the bipolar 1 diagnosis. A manic episode is described as a distinct period of abnormally elevated, expansive, or irritable mood accompanied by increased energy and goal-directed activity. Very often, manic episodes, not always, but very often, manic episodes can lead to hospitalizations, especially when they are not treated properly. So we're looking for symptoms of distractibility, impulsivity, risky behavior, grandiosity, flight of ideas, racing thoughts, increased activity, decreased sleep, and pressured speech. Importantly, the symptoms of mania can be missed in the pediatric population because they can present differently in children and adolescents than they do in adults. For example, hypersexuality looks very different in a prepubescent child than it does in an adult. Goal-directed activities in children who have to follow their parents' or teachers' rules on what activity to do when can look very different than for an adult who is in charge of what they do with their own time. Also, in children and teens, mood shifts typically happen much more frequently than in adults, where clinicians are trained to look for mood episodes that last for weeks or even months at a time. In pediatric bipolar, those mood shifts can happen multiple times in a single day. Further, and this is really important in the process of your differential diagnosis, The symptoms of bipolar mood episodes need to represent a change from baseline and be severe enough to cause marked impairment. Now, bipolar 2, often perceived to be a milder version of bipolar 1, but this is not accurate. Bipolar 2 has a distinct course of illness characterized by at least one major depressive episode and at least one hypomanic episode. Although hypomanic episodes use the same symptom criteria as manic episodes do, the effects are less intense, can be less destructive, and usually do not require hospitalization. Now, the diagnostic criteria for disruptive mood dysregulation disorder looks very different, with severe recurrent temper outbursts that can be verbal or behavioral. These outbursts occur at least 3 times a week and are grossly out of proportion to the situation or developmental level. This piece of the DSM's DMDD criteria deserves our attention. Outbursts that are grossly out of proportion to the situation and inconsistent with developmental level is a judgment call. And remember, judgment calls are subject to bias. Cultures that value emotional restraint may perceive a child expressing distress loudly as more dysregulated than a culture where emotional expressiveness is normative or even valued. In that context, the same behavior might not be flagged at all, potentially leading to underdiagnosis. So this disproportionate threshold is not a universal standard. It is filtered through the clinician's own cultural lens and the norms of the informants that they are relying on. So when you're assessing outburst severity, ask yourself, who is making this judgment and from what cultural standpoint? Between the outbursts with DMDD, again, and this is important for differentiating it from bipolar, is that in between outbursts, there is a persistently irritable or angry mood present most of the day, nearly every day. This mood is observable by others and present in at least 2 settings: home, school, with friends, out in the community. And finally, the symptoms must be ongoing for at least 12 months, with no symptom-free period longer than 3 months. There are exclusions with DMDD that are important for a proper diagnosis. DMDD cannot be comorbid with ODD, IED, or bipolar disorder. It can, however, co-occur with ADHD, major depression, anxiety disorders, and conduct disorders. If there has ever been a manic or hypomanic episode lasting more than 1 day, then the bipolar diagnosis takes precedence. Our third learning objective: identifying the clinical features that differentiate bipolar disorder from DMDD. So before we dive into the details, I want to reiterate 2 key points of differentiation that we've already discussed. In bipolar disorder, there are manic or hypomanic episodes, and the baseline mood between those episodes is not irritable. There may be irritable episodes associated with depression, but again, the baseline mood in between mood episodes is not irritable. With DMDD, manic or hypomanic episodes are an exclusion criteria, and the baseline mood between episodes is irritable. Now, to go into more detail on the specific criteria we're going to review are chronic versus episodic, illness progression and longitudinal outcomes, family history, physiological signatures, amygdala activity, symptom differences, and treatment differences. So when we're looking at differentiating bipolar and DMDD, you want to look at the symptom timeline. In bipolar disorder, you will find distinct highs and distinct lows, and this may look like periods of elevated or depressed mood that represent, as I've mentioned, a clear departure from the person's baseline. That manic episode or depressive episode can both involve irritability, especially in children. But again, we're looking for it to be a clear departure from that baseline mood that occurs in between episodes. In DMDD, however, mood does not fluctuate in this same way. The baseline for children with DMDD is chronically irritable or angry. Episodes are escalations of that irritability and anger, but not distinctly different from it. As I said, these outbursts may spike above baseline and return to an angry, irritable baseline. There are no meaningfully long symptom-free periods of time. So these two diagnoses can often be described by parents or caregivers very differently. In bipolar disorder, you might hear a parent say, "My child isn't always like this. Where has my child gone?" That's what I wonder when they are having a mood episode. But in DMDD, you're more likely to hear a parent report that this is just how my child has always been. Now, the original research on illness progression in chronically irritable children is some of the most powerful evidence that we have against the framing that DMDD is just the childhood version of bipolar disorder. So when researchers examined the longitudinal course of youth with severe mood dysregulation, remember that's the predecessor of DMDD where irritability is chronic, they found that these children were 50 times less likely to go on to experience a manic or hypomanic episode than were children diagnosed with bipolar disorder. Additional research also shows that youth diagnosed with this severe mood dysregulation at around age 10 were significantly more likely to have a depressive disorder diagnosed by the age of 18, not bipolar depression. And in the intervening years, multiple studies have consistently shown that this severe and chronic mood dysregulation was associated with later anxiety and depression and not bipolar. The American Academy of Child and Adolescent Psychiatry, ACAP, summarizes this plainly. Children with DMDD do not usually go on to have bipolar disorder in adulthood. They are more likely to develop difficulties with depression and anxiety. So if you're seeing predominantly depression and anxiety, and you have accounted for misinterpretations of mania, then you may be looking at DMDD. Looking at family history, we can see that if severe mood dysregulation and chronic irritability, DMDD, were truly a developmental form of bipolar disorder, you would expect families of children with severe mood dysregulation or DMDD to show elevated rates of bipolar disorder within the adults in the family, just as families with children who are diagnosed with bipolar disorder do. That is not what researchers found. The genetic and familial picture also points to a separation between these two conditions. The rates of bipolar diagnosis was significantly lower in parents of youth with DMDD than in parents of youth with bipolar disorder. Roughly 2.7% chance that at least one parent of a child with DMDD has bipolar versus a 33.3% chance that at least one parent of a child with bipolar also has bipolar disorder. This is an essential criteria to consider because the medications that are used in treating unipolar depression, anxiety, and DMDD are contraindicated for bipolar and will at best have no effect on the symptoms and at worst cause escalation in symptoms or activations of mania. So family history and the family presence of bipolar disorder in parents, aunts and uncles, grandparents, cousins, siblings is all an extremely relevant and essential criteria to examine during your differential diagnosis. Now, when we look at physiological factors, both patient groups report significantly more and higher levels of arousal than healthy controls when faced with circumstances that are frustrating. But their behavioral and psychosocial performance differed from each other in important ways. Regardless of the emotional context, children with DMDD had lower N1 evident related potential amplitude than comparison subjects or children with bipolar. This relates to impairments in initial stages of attention. The N1 is a brain signal that is linked to basic sensory and early attentional processing. The fact that this deficit appears regardless of whether the task is frustrating or neutral means that children with DMDD have a more pervasive baseline attentional problem, not one that is being triggered by emotional states. In contrast, the frustration condition for children with bipolar disorder had lower P3 amplitude than children with DMDD or with the comparison subjects, reflecting impairments in executive attention. The P3 component is a brain signal that is associated with higher order attentional allocation, cognitive processing, higher order executive functioning. Its reduction in children with bipolar disorder, including frustration, suggests that the frustration specifically disrupts their top-down cognitive control and is triggered by emotional states. In other words, frustration disrupts stages of the attentional pipeline differently depending upon the diagnosis. The psychophysiological anxiety in bipolar subjects was isolated to the emotional condition, whereas in DMDD, the deficits were seen in both emotional and non-emotional conditions. This pattern points to a fundamental difference underlying neural mechanisms, not two different versions of the same disorder. Now, researchers in 2010 used functional MRI to examine how children with DMDD, or severe mood dysregulation, as it was called at the time, and bipolar, processed neutral faces as compared to their healthy controls. This task sort of taps into the social emotional interpretation and the activity in the amygdala, a brain structure that is central to threat detection and emotional reactivity. Children with the severe mood dysregulation condition showed decreased amygdala activation relative to both the bipolar youth as well as healthy controls when they were rating their fear of neutral faces. This may seem counterintuitive on the surface. These are chronically irritable children. You might expect their amygdala to be overactive, but instead it is underactive compared to children with bipolar and their healthy controls. By contrast, previous research has found increased amygdala activation during face emotion processing in pediatric bipolar disorder. So children with bipolar show amygdala hyperactivation to its ambiguous social cues, while children with DMDD show amygdala hypoactivation, opposite patterns. This face labeling deficit is a surface level similarity, with both groups struggling to read emotions on faces, but the brain mechanism producing that difficulty are distinctly different. So let's look at the key distinguishing features. Notice that grandiosity and decreased need for sleep, which are hallmarks of mania, are absent in DMDD. The child with DMDD is still going to bed, is still sleeping, but is still chronically angry and reactive. Euphoric or elated moods or other previously mentioned symptoms of mania are also notably absent in DMDD, with a mood that is persistently negative and non-expansive. Thinking about these distinctions together should help you make a defensible differential diagnosis in most cases. Now, here's where things get tricky again. Remember, irritability is transdiagnostic, meaning that it is present in both disorders. It also appears in ADHD, in anxiety, in unipolar depression, and even trauma presentations. Again, the key distinction is not just whether or not irritability is present, but what kind of irritability it is. This is a nuanced examination. In bipolar disorder, irritability is episodic. It emerges as part of a mood state and it resolves. In DMDD, however, the irritability is more known as chronic and the child's resting state. As a clinician, you gather your data for that differential diagnosis. And during that process, you can ask the parent or caregiver to think about their child and to ask them to examine what would they consider a good day to look like, and how would you describe their mood? Their answer there will give you really important information as to whether or not that irritability is going to be chronic or temporary. With DMDD, the child will likely be described as irritable or on edge, even on good days, whereas a child with bipolar disorder will be described as back to normal on a good day without irritability. So as I mentioned earlier, it's really important to remember that expressions of irritability are not culturally neutral. Research on childhood anger and emotional dysregulation across cultures consistently find that what is labeled as irritable behavior and whether or not that irritability is even reported to clinicians based on that perception varies significantly by cultural context. For example, in many Asian American communities, there are strong cultural norms around emotional restraint for children and prohibitions on children expressing negative emotions, particularly anger, towards authority figures like parents and teachers. In contrast, some Latin American and Caribbean communities consider emotional expressiveness, including displays of anger, to be acceptable and are far less likely to be pathologized. It is also important to remember that these are merely generalizations and may not apply to the person who is sitting in front of you in your office needing support around diagnosis. So it is extremely important to check in with your patients to make sure you are not making assumptions about how they individually or collectivistically interpret expressions of anger. Find out what their own individual expectations are of their children so you can benchmark the irritability factor against what can be expected for this individual that you are assessing. Also important to take into consideration are your own biases and preconceptions, many of which are unconscious, we are unaware of, intend no harmful outcome, and with examination can be accounted for like an extraneous variable in an experiment. I just want to say that one more time. Please, when you're working towards an accurate diagnosis, reflect on all of these factors, cultural, individual, and personal. Ask parents their expectations and examine your own. Now, a compelling differential diagnosis can be challenging, and it is important to touch on some common errors that happen during differential diagnosis. The first is, as we've mentioned, misunderstanding and misidentifying manic episodes as hyperactivity or temper tantrums or looking for adult presentation. This can be really detrimental to your differential diagnosis process. Second, if you fail to look at the episodic versus chronic nature of this irritability, you will be missing vital information. Without mapping out the timeline, you cannot make this differential diagnosis. Third, relying on a single source of information can limit your perspective. If you are hearing from a parent, they may minimize or conversely catastrophize scary symptoms. If you're hearing from a teacher, they don't see or hear about symptoms that happen at home most of the time. So you need multiple sources of information. So you have multiple reports from multiple settings. Fourth, if your entire clinical frame is drawn from research that is conducted primarily on white samples, you are applying culturally specific yardsticks to a universally diverse patient population. That is a structural problem that we need to counter and address in our practice. Finally, diagnosing during a crisis is not appropriate. This happens more than we may realize, for the simple fact that families ask for help most often when they're in crisis. We don't tend to hear from families where everything is going along beautifully. And so when families reach out, schedule that first appointment, come in for that first appointment, very often they are in a state of crisis. They are in acute distress. You are seeing that parent and that child at their most overwhelmed, at their most challenged, their most distressed, and their most dysregulated. That is not comprehensive data for your differential diagnosis. I know we are pressured for reimbursement purposes, for institutional purposes, to assign a diagnosis quickly. But it is absolutely necessary to reserve your diagnosis until you've been able to do a differential diagnosis, assessing data that you've gathered over time and across settings. Further, we need to note that pathologizing adaptive responses is problematic. A child who is living in a high stress environment marked by poverty, abuse, neglect, community violence, systemic discrimination, or some form of family instability may show chronically irritable behaviors and dysregulation. They, in that case, are still very real dysregulation and chronic irritability, but it's an adaptive response to a threatening context and not evidence of any mood disorder. So differentiating between bipolar, DMDD, mood disorders in general, and trauma is extremely important. But that is a different training altogether. So that is all that I will say about it in this context. On to our fourth learning objective. Give examples of current evidence-based treatment approaches for both bipolar and DMDD. So you have in front of you a diagnostic decision tree, for lack of a better term. And you can use this to structure your thinking. Start with, is there irritability and outbursts? If the answer is yes, then ask, is the mood episodic with a return to a pleasant baseline? And if the answer is yes, pursue a bipolar workup. If the irritability is chronic with no symptom-free period, with an onset before age of 10, yes, then without this baseline of pleasantness, pursue a DMDD workup. In both pathways, review and examine. Ask about issues related to trauma, their medical history, and any comorbid diagnoses. All of these questions shape treatment even when the primary diagnosis isn't clear yet. And at every branch of your decision making, document your reasoning. Now, the simple fact is that families come to us wanting answers, and saying, I'm not sure yet, can feel like a failure and can be frustrating for you as the clinician as well as for the family. But it is actually, in some cases, the most ethical and clinically sound position you can take when the picture is unclear. I find it helpful to frame uncertainty as active and purposeful. Being able to say to the family, what I can tell you right now is that your child is living with significant emotional dysregulation that's causing involuntary symptoms, not intentional behaviors. Here's what I'm doing to try to understand it better, and here's what we can do to start helping now. That's a workable clinical stance. Document your diagnostic thinking clearly, not just your diagnosis, but your reasoning as well, because it is your reasoning that is examining what you are watching for over time and across settings, and it is your reasoning that will back up and support the diagnosis that is ultimately given. Now, in treating DMDD, psychosocial interventions are first line. Parent management training has the strongest evidence base for reducing explosive behavior and improving family functioning. Cognitive behavioral therapy can be useful in targeting frustration tolerance and emotional regulation. And research has specifically showed that CBT is effective for core DMDD symptoms of anger and irritability because there is continued accessibility to those higher attentional and executive functioning skills that we talked about earlier when we were looking at the neurobiological differences between DMDD and bipolar. DBT adaptations are also used in adolescents who can target their distress tolerance and emotional regulation. And finally, school-based supports are critical and often underutilized, such as IEPs, 504 plans, which can reduce the setting-based triggers that drive outbursts. While there's no FDA-approved medication for DMDD itself, psychopharmacology in treating DMDD is almost always targeting a comorbid condition. So as Dr. Post mentioned, in this case, SSRIs that are used in treating DMDD aren't treating the core diagnosis of DMDD itself, but they're treating those comorbid conditions such as ADHD. ADHD is a common comorbid condition, and so using a stimulant is appropriate and may actually reduce irritability as well as improve attentional symptoms. If anxiety or depression appears to be comorbid, that SSRI may be appropriate. Atypical antipsychotics or second generation antipsychotics are sometimes used for severe irritability or aggression, but the truth is the evidence is limited on the use of antipsychotics, and the side effect burden is significant and requires serious risk-benefit analysis prior to commencing treatment with antipsychotics. There are metabolic side effects such as weight gain, cholesterol issues, and metabolic syndrome. And there are also what are called extrapyramidal symptoms or EPSs, such as tremors and akathisia, which are movement disorders. Finally, research has shown significant overall improvement in DMDD-related irritability with both the pharmacological and non-pharmacological interventions. Treatment for pediatric bipolar disorder, however, is substantially different. And while we do use a multimodal approach, medication is a central first-line tool in treating bipolar disorder. Mood stabilizers, such as the gold standard lithium, have the most safety and efficacy in youth. We have research on lithium's safety and efficacy going back the longest of any medication out there. And while some prescribers worry about the required blood work that goes along to maintain lithium's narrow range of therapeutic effect, it is still the gold standard for treating bipolar disorder at any age. Other mood stabilizers, a class that were originally developed as anti-seizure medications, are also useful, especially when they're used in combination with lithium. There is support in the literature for the use of lamotrigine, especially in bipolar II disorder, which tends to predominantly include episodes of depression, because lamotrigine has been shown to be useful at addressing depressive episodes and phases, whereas oxcarbazepine is often used in combination with lithium for treating manic phases. It is used to treat manic episodes that are elevated, irritable, or aggressive. Psychoeducation is critical for medication adherence and early episode recognition, and it needs to be a foundational part of any treatment plan, as does the other psychosocial and school-based interventions and accommodations. Now, when we're talking about pharmacological interventions, though, it is extremely important to interject this moment of caution. Antidepressants and stimulants have both been shown to trigger mania in children and teens and adults with bipolar disorder. They can experience manic episodes. They can experience mixed mood episodes where elements of mania and depression are present at the same time. Mixed moods episodes are especially dangerous because of the possibility for suicidal ideation and activation. It is recommended to avoid their use until bipolar disorder can be ruled out. The risk of mood destabilization is very, very real, and it has very real potential harms associated with it. Now, in the treatment of bipolar disorder, family-focused therapy is strongly supported in the literature for reducing relapse and improving functioning in youth with bipolar disorder. Family-focused therapy has been studied in both predominantly white and diverse samples, and it has shown effectiveness across groups. However, the foundational part of the family-focused therapy model assumes a relatively stable family unit with consistent parental involvement, which may not always be the case when we are facing bipolar disorder treatment. And so an assumption of its efficacy may not hold true for families who are experiencing housing instability, parental incarceration, parental hospitalization, immigration stress, or multi-generational caregiving. Clinicians implementing family-focused therapy or FFT adapted approaches with BIPOC communities or low-income communities should be prepared, according to the literature, to modify things like session format, location, and pacing to account for real-world barriers to engagement. In a few weeks, in May, we're actually going to be hosting a free webinar with Dr. David Miklovitz, the creator of FFT, discussing family-focused therapy in greater detail. Now, stigma. Psychiatric labels given during childhood feel like they carry extra weight and carry well beyond the clinical chart. They affect how parents see their child, how teachers and coaches interact with them, how a child understands themselves, and what misinformation their peers may be getting about what those diagnoses are and what they mean. It doesn't mean that we should withhold diagnosis, though. Diagnosis delayed is treatment denied. And so children and families deserve the explanatory framework and access to services that a diagnosis provides. But it doesn't mean that we should apply diagnoses willy-nilly. They still have to be, after a differential diagnosis, applied carefully. We need to communicate with families thoughtfully and revisit the diagnosis as the child develops and new data becomes available to us. The fact that a child still has additional developmental stages to go through doesn't mean that they should be denied an accurate diagnosis. It means that they should have access to a clinician who is willing to periodically review, take in new information, both from the research as well as from the patient, and be willing to do a new differential diagnosis as it is warranted. We also want to note here that the expression of irritability, help-seeking behaviors, and tolerance for emotional outbursts is once again going to vary significantly across cultural contexts, and we need to examine our own assumptions about what constitutes disproportionate behavior. Stigma can also be a very real and significant barrier to treatment seeking and to engagement, particularly in communities where mental health problems are seen as shameful, a sign of a family or a child's failure, or as something that needs to be handled privately. Explicitly naming stigma, not hiding from the reality of it, but explicitly stating it, saying, I know some families worry about stigma and what a diagnosis like this might mean, but we can work through that. We can talk about it and we can process those feelings as we pursue appropriate treatment. Normalizing it, normalizing the diagnosis, normalizing the help-seeking behavior within a culturally sensitive frame can meaningfully improve engagement. It also helps families ask questions about that framework, about that diagnosis, and helps them to engage in the clinical process in appropriate and beneficial ways that influence outcome. Now, research consistently shows that Black children with the same behavioral presentations as white children are more likely to be diagnosed with conduct disorder than bipolar or DMDD. This is a label that carries profound social consequences, including involvement with the juvenile justice system. These conduct disorders are less likely to be diagnosed with mood disorders, which would channel them toward treatment. These implicit biases operate below conscious awareness and shape critical decision-making in ways that clinicians are often unaware of. In the context of our topic today, this means that a Black child with mood dysregulation may be less likely to be understood as experiencing genuine, involuntary emotional distress as the result of the symptoms of a mood disorder, and more likely to be perceived as intentionally and willfully acting out or being defiant. That perception has very real and very direct consequences. There's also a well-documented pattern of Black adults with bipolar disorder in particular being misdiagnosed with schizophrenia. Their mood dysregulation and symptoms are often overlooked in favor of an overemphasis on psychotic features. And in 2023, Lee and et al. Published a study in the International Journal of Bipolar Disorders that showed Black individuals with bipolar disorder in the United States were significantly less likely to be prescribed traditional mood stabilizers than white individuals, which contributes to that cycle of worsening outcomes. A 2023 review in the American Journal of Psychiatry concluded that racial and ethnic bias is one of psychiatry's most persistent and consequential diagnostic inequity. And for Latino youth, research shows that anger and irritability symptoms are more often attributed to cultural temperament or behavioral problems rather than being recognized as legitimate indicators of mood disorder and its involuntary symptoms, contributing to underdiagnosis and delayed treatment. So what does this mean on a practical level? This means that we each carry with us the responsibility to examine in our own clinical practice our decision-making trees for bias. When you find yourself reaching for a behavioral or externalized diagnosis for a child of color, ask, would I make this same diagnosis, this same clinical diagnostic judgment if this child were white, or if this child were the same race that I am, or if they were a different race than I am? When you see behavioral presentation that seems consistent with anger or conduct problems, ask, am I adequately screening for mood? When referrals come in labeled as oppositional or labeled as defiant, ask, who made that judgment? And what was the standpoint from which they made that judgment? These are not always comfortable questions. We don't always like to look at this or talk about it or think about it, but they are necessary ones if we are going to be giving appropriate care with diagnostically appropriate treatment. So we've covered a lot of ground, and I want to use these last few minutes to pull the most important threads together. Much of what we've discussed today hinges on one concept: the difference between episodic and chronic irritability. In bipolar disorder, mood changes are periods of elevated or depressed, expansive, or irritable mood that represent a clear departure from who that child actually is. And then after those episodes, there is a return to baseline. In DMDD, there is no return. The baseline is irritable. Chronic, persistent irritability punctuated by outbursts with no meaningful symptom-free period is the key. If you hold on to nothing else today, hold on to that distinction. It is the clinical compass for this differential diagnosis. And remember, distinct is the operative word in bipolar disorder. You should be able to point to a time, a month, a season, a school year, a day when the child was different. When families tell you, this just isn't how she's always been. This isn't how he always is. He's sweet. She's kind. My child is empathetic in between mood episodes. This is history and diagnostic data pointing towards an episodic illness, not a chronic one. In bipolar disorder, there are also manic episodes that cycle in patterns over the course of a week or days or even hours in the case of ultradian cycling. Now, again, our next key takeaway: the diagnostic compass only works when you have good data. Your diagnosis is only going to be as good as the data you put into that differential. So good data requires population information over time from multiple informants in a longitudinal framework from and expanding over time. One parent telling you that their child has been irritable lately is not enough. You need teacher observations, developmental history, a timeline that maps mood and behavior across months and across settings. I want to especially underscore this distinction between outbursts and episodes. It is a common error that I see in consultation with providers and families. A clinician is told about an explosive, severe behavior, and because it can apply to either diagnosis, the clinician reaches for the diagnosis they are most familiar with. But a temper outburst lasting 20 minutes with continued chronic irritability in between is not a manic episode. A manic episode involves a distinct shift away from a non-irritable baseline. And that distinction has to be explicit in your clinical thinking and in your documentation. I want to be direct here because it's where the stakes are highest. Diagnosis drives and dictates the treatment options that are offered. The treatments for bipolar and DMDD are meaningfully different, and applying the wrong treatment can cause real harm. If a child with unrecognized bipolar is given an antidepressant or a stimulant, both of which are contraindicated for bipolar disorder, it is likely to trigger a manic episode, a mixed state, or result in hospitalization. When you are genuinely uncertain, as we've said, there will be cases where uncertainty is appropriate, honest, and the ethical choice. The safest choice is to consult with colleagues who are trained and can provide specialized insight into the presentation of these disorders to help with the differential diagnosis process. And finally, cultural considerations are not peripheral. They belong at the center of all clinical work. The research base we draw from is predominantly Western and predominantly white. What is considered disproportionate emotional behavior is not a universal standard. It is a judgment filtered through cultural norms, and those norms vary. When you are assessing a child from a cultural background different from your own, ask explicitly how the family understands and contextualizes that behavior. Ask about experiences of discrimination and of experiences of stress. And examine your own assumptions and contexts for understanding the behaviors that are described to you. Without this awareness, we are perpetuating a systematic failure with individual consequences. So each of us has a responsibility to counteract it in our own practice. As we wind down, I want to leave you with one important thought. The children that we've been talking about today, the ones who have to actually live with their symptoms, such as outbursts and chronic irritability, are some of the most misunderstood children in our clinical, psychiatric, and psychological systems. They get suspended. They get referred over and over and over again for being too complex. They get labeled and relabeled. They are constantly being told, no, stop it, don't do that. They are asked to control involuntary symptoms. At the same time, they are very infrequently told that they have done a good job or that their struggles are understood. Their symptoms exhaust them and have repercussions that impact them and their families, their teachers, and sometimes their clinicians. In the middle of all of that, it can be easy to lose sight of who they actually are. These children are not hard to love. They are not hard to support, and they are not hard to root for. Their symptoms are hard for them to live with and for their families to live with. There is a big, important difference here. The families sitting across from us in our offices, the parents who are tired and scared and sometimes angry, they love their children fiercely. What they need from us, their providers, is someone who will do the hard clinical work of truly understanding what is driving their child's suffering not just what it looks like on the surface. They deserve clinicians who won't stop asking questions just because the answer is complicated. So before we go, let's check one more time. After this webinar, how confident do you feel in differentiating DMDD from bipolar disorder in your practice? I would love to see a movement towards fully confident, but I also want to normalize that somewhat confident is honest and appropriate place to be after all this time with a genuinely complicated topic. We will be able to answer more of your questions during the Q&A, which we are about to start. The goal of today was to give you a framework, not a formula. And you'll continue building this skill every time you sit with one of these families and do this kind of differential diagnosis. Now, on these next slides, you will see the articles that were used, the peer-reviewed published papers that support the information that was included in this presentation today.